Good morning. So, welcome to this rapid fire session, which is rapid fire academia, research, teaching, education in ophthalmology and translational research. And I'm joined with my co-chair, Dr. Bhavna Chawla. And the sequence is already there in the program. Just as a housekeeping announcement that presentations are only for 5 minutes. And apparently there will be a warning at 4 minutes, and at 5 minutes you have to close. There's a 1-minute discussion time as well. And since I understand this is a session which is being graded, so please try to stick to time. So all the best to the presenters, and we'll begin with the first presenter, Dr. Vishal Bhambawani, who would be talking on simulation-based ophthalmology education for medical students in Canada, a pilot project. Over to you.
Thank you. Good morning, everyone. I'll be presenting our paper on the use of simulation-based ophthalmology education for medical students in Canada. Thank you. These are my financial disclosures. So the International Council of Ophthalmology recommends a certain minimum standard for ophthalmology exposure during medical school. However, despite this, ophthalmology is an underrepresented specialty in many medical school curriculums, and literature shows that this leads to lack of confidence in medical students and clinicians when dealing with eye conditions, and the standard of primary ocular care can be made better if more effective undergraduate ophthalmology teaching could be practiced. So what is simulation-based education? So simulation is a method of instruction which involves creating a realistic scenario which mimics real-world situations, and this allows students to practice skills in a safe environment and without risk to the patient. Now, there is a lot of literature on the use of simulation-based education in medical training, but very limited literature regarding its use for ophthalmology education. A lot of these simulation-based education exercises involve simulators which are very expensive. So our study actually aims to evaluate use of low-cost simulation-based education methods in ophthalmology training for medical students to increase their knowledge, interests, and skills in ophthalmology. So this was a prospective study which was conducted at the Northern Ontario School of Medicine University in Thunder Bay, Ontario, Canada. A second-year NOSM-U medical students participated in a 2-day workshop which involved simulation-based ophthalmology training by an ophthalmologist and a simulation educator. The initial information was presented to students in the form of a PowerPoint, and then we used standardized patients, eye models, and simulator models to impart education on clinical and procedural ophthalmology skills, which included vision assessments, slit lamp examinations, ophthalmoscopy, retinoscopy, ocular motility assessments, laser procedures, and steps of cataract and strabismus surgery. So the figure A is an eye model which is used to practice steps of cataract surgery. B is an eye model to practice steps of strabismus surgery. C is one of the American Academy of Ophthalmology simulators, which is used to assess ocular motility and strabismus assessments. And D is shows simulator models which are used to practice ophthalmology laser procedures. This is again one of the models that is used to practice cataract surgery. Now, we used questionnaires to evaluate learners' ophthalmology experience, interest, and knowledge before and after the workshop. And we also gave them a feedback survey to assess the quality and usefulness of the workshop. So 9 students participated in the workshops, and we found that compared to pre-workshop, immediately post-workshop, we found that there was a statistically significant increase in learner confidence, interest, and knowledge. And a lot of these were maintained even 3 months after the workshop. Regarding the feedback questionnaire, the usefulness and the effectiveness of the workshop was rated very high, and the overall educational value of the workshop was rated to be 4.9 out of 5. So most of the students felt that the workshop was very relevant, comprehensive, easy to understand, and they gained knowledge and skills which they could apply to their future clinical practice, and they also recommended that such activities should be included in the medical school curriculum. So our study shows that even using a low-cost simulation-based training exercise can improve medical student knowledge, skills, confidence, and interest in ophthalmology, and this could be done in a learning environment that students find comfortable and enjoyable. These are our references. Thank you.
Yeah, so we open it up for discussion. Nice presentation.
Thank you.
So if there are none, let me begin that across the training models, like you had a kind of a significance over those 9 students, right from the baseline to the first one, and then it progressed again. So in the last one also there should be significance if you consider from the baseline, right? Or was it from the...
Yes, yes. So we did the questionnaires and the survey was done at baseline and immediately after the workshop and then 3 months after the workshop. So there was statistical significance at all the intervals, but we found that the scores for ophthalmology knowledge, for example, were higher immediately post workshop compared to 3 months after. But compared to baseline, it was still significant. Any other questions? Thank you. Thanks.
All right, so it's my pleasure to invite the next speaker, Dr. Wendy C. The topic is a survey of Asia Pacific Academy of Ophthalmology members' attitudes toward operating room waste and sustainability efforts.
Thank you. Good morning, everyone. I'll be presenting a survey of Asia Pacific Academy of Ophthalmology's APAO's members' attitude towards operating room waste and sustainability efforts. Now, do you know that one phacoemulsification in the UK generates carbon dioxide emission equivalent to driving a car for 500 kilometers? That is 20 times more than a phacoemulsification done in India in Aravind Eye Center. So now that creates a very deep concern regarding our work as ophthalmic surgeon to the environment. Sustainability surveys has been conducted in North America and European in 2020 and 2023 respectively, and they reveal a strong willingness amongst ophthalmic surgeons to adopt a more sustainable practices in the OR. What about the Asia-Pacific ophthalmologists? Are we willing to? Hence, to answer that question, a special task force has been formed in 2024, led by all these people, and I thank them sincerely for their guide and support in this project to answer that question. An online survey was distributed to all the members of APAO via emails, February to March this year. The survey, the presentation that I'm presenting is a preliminary data. The survey is currently still ongoing. The survey is available in English and it has been translated to Mandarin and Japanese languages. Similar questionnaires were used from the previous sustainable studies to allow for direct regional comparison. This is our results. So far, we have close to 2,000 respondents, majority from Japan, followed by Indonesia, China, the Philippines, Malaysia, and etc. Majority of the respondents have more than 10 years of experience. They are high-volume cataract surgeons. They work in a public or government hospitals. Majority are male. So this is the result. Close to 94% of the ophthalmologists in Asia-Pacific are concerned about global warming and climate change, and this closely mirrors to the result done in the previous study in North America and the European ophthalmologists. So when asked what was the perceived driver of OR waste generated in the OR, 2/3 agrees that manufacturers play an important role in reducing the OR waste. We want the manufacturer should offer more reusable instruments, and that manufacturer should consider the environmental impact in their designing and their packaging. More than 60% agrees that regulatory body should allow surgeons discretion in reusing these medical supplies, and that medical society should advocate for it, and that we do need more clinical studies to prove the safety of reusing these medical items. So this is an interesting data that we have. A higher proportion of respondents in the Asia-Pacific are currently reusing these medical supplies as compared to our European friends. More than 60%, 2/3 are currently reusing phaco tips and IA tips. 40% are reusing both the phaco and IA tips. More than half of them are reusing irrigation solutions or bottles for more than one patient. And for those who are currently not reusing, 1 in 5 are willing to consider doing so. The same goes for intraocular pharmaceuticals. And comparison across the regions globally, concerns for endophthalmitis risk and malpractice sustainability significantly reduce the willingness of reusing these supplies. That is very reasonable. And factors such as cost saving and environmental consideration are the factors that increases our willingness to reuse supplies on multiple patients. Factors that drive for single-use instruments are, the major factors are patient safety, performance of the instruments, and we do not want to get sued. So if you could choose between equal functionality, equal performance, and equal cost, 65% of ophthalmologists in the Asia-Pacific would prefer to use reusable instruments, 77% in the European region. So in conclusion, the result of this preliminary survey of almost 2,000 respondents closely mirrors to the ones done previously in the European and in North America. More than half of us are already reusing and are willing to reuse these medical supplies and pharmaceuticals, and we rank pretty similarly in terms of the factors that influence our willingness to reuse these supplies. And this adds on and gives a strong consensus that ophthalmologists worldwide are very concerned about global warming and climate change. With that, I thank you.
Thank you. That's a very interesting presentation. We open it up for discussion.
Come again? This survey has run only for a month so far, so this is just a preliminary data. We have close to 2,000 respondents so far. We are pushing through our medical societies. Yeah. Mm-hmm. We just blasted emails twice through the APAO emails. Yeah.
So did you approach APAO for giving you the email database of all the members?
Yes, I did. It's a long way, and translating into Mandarin and Japanese is also a long process. Getting it done, and funding, of course. Yeah. Two Mandarin and Japanese, and it is available in English. Yeah.
Thank you. We move on to the next presentation, which is by Rese. So did I pronounce it correctly? Dr. Pei Yuan He. Do you have any recorded presentation? No. So we move on to the next presenter, which is Esmeralda Lo Tang, and her talk is on census data reveals inequity in self-identified visual disability in New Zealand Atoria.
Namaste, kia ora koutou, talofa lava, and warm Pasifika greetings to you all. My name is Esmeralda Lotam, and I am from the most southern part of the South Pacific, New Zealand. And today I'll be talking to you about the census data, which is a nationwide survey carried out every 5 years in New Zealand. So looking specifically at the 2018 census, this was the 34th census in New Zealand, but the very first one to be completed online. It was also the first to ask the question, do you have difficulty seeing even if wearing glasses? Now, Pasifika health is detrimental to the health status of Aotearoa New Zealand, because if we reflect on the population increase, we see that the Pasifika population has increased exponentially over time. Now, this table we see shows a prediction of answering the questions on self-identified visual disability, where subjects were more likely to answer if they were older or female, and less likely to answer if they were Māori or Pasifika. And comparing the three ethnic groups, and taking the females for example, we see that the other ethnic groups, the bars on the far right, have significantly less self-identified visual disability in both age examples in comparison to the Māori and Pasifika in both age groups used here. So now let's paint a picture of Pasifika life expectancy versus the total population in New Zealand. And what we see is the Pasifika population pyramids on the left reveal a bell-shaped curve which reinforce the impact of early life risk factors, such as smoking and obesity. The general New Zealand population pyramid show a more even distribution, reflecting a longer life expectancies with lower burden of early life chronic diseases. And so what does this mean in relation to visual health for Pasifika communities? The consistent age structure over time means that long-term planning for youth-focused visual health services is essential. Therefore, there's a greater need for earlier prevention and intervention strategies in eye care for Pasifika communities. Of course, with any study, there are limitations, and there was no exception to the census here. One of the major limitations was that we had received the lowest response rate in over 5 decades, a 9% drop from the previous 2013 census, and well shy of the 94% national target. Implications were said to be due to this being the first online census, and implications or challenges that come with that, like are people digitally literate? Do they have access to a computer or to internet? Despite this, there are various benefits, and that's what I want to highlight here. It is a big data set. It's the first of its kind, which is new, and it's very exciting. And although it's limited data, it is the most complete that we have at this stage. So overall, the intention of this research is simple, to have more equitable incentives and initiatives. So more Pasifika-based research to provide stronger evidence for Aotearoa and the Pasifika nations, to have increased accessibility to eye health care and remove barriers for health care for marginalised and Indigenous populations, and also to have preventative care prioritised and health education. Of course, none of this research would be possible without my wonderful supervisors and sponsors and scholarships who have flown all the way here from New Zealand just for today. Thank you for the opportunity.
Thank you for that nice presentation. And we open it up for quick questions. I just wanted to ask you, what proportion of the Maoris and the Pasifika, right, that group, yes, what proportion of that comprises the overall population? Like,
that is a good question. That's a question that I don't have the answer to right here, right now.
And the second follow-up question to that I had was, you said that there were barriers in seeking eye care. So what were the potential barriers?
Some of them are language. For Pasifika people in New Zealand, English is still a second language. And even when we translate it into Samoan or Tongan languages, the medical terminology is also different. So just I guess, the health literacy around understanding getting preventative care earlier rather than later when it's more severe and complicated. Yeah.
It's okay. If there are no more questions, thank you very much.
Sorry, I haven't got rid of me yet. Okay. Yeah, sorry. All right. Now we turn our gaze to understanding. Oh, what happened? Now we turn our gaze to understanding the state of ocular disease and inequity disease burden among Pasifika residing in Aotearoa. According to the Global Health Commission, eye health is maximised vision, ocular health and functional ability, which contribute to the overall health, well-being, social inclusion and quality of life. So what is the cost of visual impairment? And on an individual scale, this means poorer quality of life. So not being able to see a whiteboard in a classroom, for example, which restricts access to achieving good grades academically and professionally, and therefore becoming more reliant on social care. On a societal level, global productivity loss due to visual impairment is estimated to cost $410 billion annually, a huge economic strain on a country with limited resources. And so what does this mean for New Zealand? With a population of just over 5 million, Aotearoa is a small developed country, and in comparison to where we are sitting today, look at where Aotearoa is, geographically isolated from the rest of the world. Furthermore, the New Zealand health system is predominantly publicly funded, which puts huge pressure on an already strained workforce and its resources. In 1945, Pasifika made up less than 1% of the population. Fast forward to today, we make up approximately 8%. However, it has been reported that Pasifika experienced disproportionately poorer health outcomes, which extend to eye problems. So a literature review was conducted to understand the state of eye health for Pasifika in New Zealand, identify barriers, and look at future directions of eye care. The literature review was conducted in September of 2023, and keywords were used to combine and modify the results. Over 600 papers were retrieved with our key concepts. However, 42 papers met the criteria. So, what were the findings of our review? Core reports showed that the literature review identified Pasifika eye diseases fell into these areas. Pasifika are overrepresented with keratoconus in Auckland, with more severe disease progression and younger age of diagnosis. Now, this is the stat that I find very interesting. Although we make up 8% of the population in New Zealand, around about 43% of corneal transplants are required for Pasifika people, keratoconus eye drops. There's an overrepresentation of Pasifika who have cataract, and that's thought to be due to lifestyle, things such as diabetes, cigarette smoking. Cataract is the most frequently performed surgery in Aotearoa, where 50% of surgeries are in the public system. And although Pasifika have lower rates of health insurance, 50% of surgeries are in the private. And we present with cataracts 10 years earlier as well than the general population. In Aotearoa, approximately 1,200 deaths are caused due to diabetic complications, where 90% of diabetes in Aotearoa are type 2. And Pasifika have twice the rate of diabetic complications in comparison to the general population. Despite AMD being the leading cause of blindness in New Zealand, we have the lowest funding of AMD treatment in the OECD and a relatively low ophthalmic workforce. In relation to Māori and Pasifika, there are low reported numbers of AMD due to low utilisation of health services. For glaucoma, there is currently incomplete data available for Pasifika. Cost is a major barrier as treatments are not publicly funded, making regular checkups less affordable. And in some regions, people need to travel long distances for care, so access is limited. Missed checkups delay recovery and impact long-term eye health. Oh my gosh. But one of the biggest challenges culturally are our priorities. As Pasifika people, we often put our family, our church, and our community obligations before our own health. And that doesn't mean that we don't think our health is important. Culturally, it is our obligation to put God first and then others before ourselves. This then translates into how we perceive our own health priorities as being second to everyone else's. This mindset can lead to delayed care and worsening of vision conditions over time. My aspirations for this research is to have equity-focused initiatives to improve outcomes for marginalised populations, so that families like yours and mine can thrive in today's world. We can transcend boundaries of ophthalmology together. Thank you, APAO.
How can we apply this knowledge in a broader perspective worldwide? As in, inequity exists beyond the area of New Zealand. So can we use this information to suggest some broader directions?
Yeah, that's a really good question. And I think in Samoan we have a saying, "E fole ala mea, le ala mea." So what we do is, that means that the solution lies within the community itself. So that's where we need to start, in the backyards and in our own homes. And I think what we want to do is take the vision screening out into the community groups, of course with our leaders and the knowledge and things like that, and be able to put it in a way where, to answer your question before as well, so that we can break down that knowledge, make it easier for people to understand, and have it not only in their languages, but for us Pasifika, we're not always able to read and understand things straight away, but visually, that's where you can capture us. So things like videos, breaking things down into learning information in different ways, and not just the usual classroom kind of setting. But yeah, does that answer your question? Sorry.
Yes, definitely. So in India, I'm sure that will be quite relevant as well.
Yeah, the other thing I wanted to ask you is with regards to the strategies, like monitoring, for instance, whether when they have a condition. So are there strategies of the government to kind of decentralize the care, in the sense that they don't have to come to cities all the time or into big tertiary centers, but are there other centers which can kind of handle this kind of regular monitoring? For instance, if it is refractive errors, you can have primary health care centers and others who could be trained or equipped to kind of deliver. So are there such strategies also?
That is also a really good question. And what we saw during the COVID outbreak and the pandemic, what New Zealand did really well is work around communities. So there were community hubs where things like churches, marae, those kind of groups, where people would go to and not only have information distributed and health awareness given to them, but doctors and nurses were able to come into those communities as well and share their knowledge. But also, I think with the follow-up, it's also having it in their own areas where they're comfortable. Once they are equipped with the knowledge there, then they'll be more comfortable to go out into the primary healthcare and things like that for follow-ups. Yeah, I hope that answers your question. Thank you for your time.
Thank you.
So I would like to invite the next presenter, Dr. Yumeng Shi. Is Dr. Yumeng here?
Hello everyone, my name is Yumeng Shi and I'm from the Eye and ENT Hospital of Fudan University in Shanghai. Thanks for giving me the opportunity to present here, and today my topic is changes in aqueous human metabolites and their relationship with post-operative macular edema in NPDR patients undergoing cataract surgery with anti-VEGF treatment. We know that macular edema is a common cause of vision loss after cataract surgery, and in diabetic patients, the risk of developing post-operative macular edema, whether DME or PCME, is both significantly increased. This risk is especially higher in patients with diabetic retinopathy, which is DR, where the incidence of post-operative edema is even greater. For DME, the ETDRS previously used clinically significant macular edema CSME as the threshold for treatment. However, more recently, a classification system developed by drcr.net has become more clinically relevant. According to this classification, DME is now categorized into center-involving DME, which is CIDME, and non-center-involving DME, which is NCIDME. The diagnostic criteria are based on OCT imaging, where CIDME is characterized by the accumulation of intraretinal or subretinal fluid in the center of the macula, along with thickening of the center area with a diameter of 1 millimeter. So this is the DME classification standard published by the drcr.net in JAMA Ophthalmology, which is a little bit of complex, but in summary, NCIDME refers to an increase in retinal thickness outside the central 1 millimeter area without involvement of the center of the macula. On OCT images, fluid accumulation is observed, but the fovea remains normal. However, CIDME refers to an increase in retinal thickness within the central 1 millimeter area, with OCT images showing significant fluid accumulation in the fovea area, usually accompanied by vision loss. And studies have shown that in patients with NCIDME, the risk of developing CIDME after cataract surgery is significantly increased. And patients with a history of DME treatment have a higher risk of developing into CIDME after cataract surgery compared to those without a history of DME. Therefore, taking preventive measures against macular edema is particularly crucial for the visual recovery of patients with non-CIDME. And currently, anti-VEGF is a first-line therapy for center-involving DME and is also applicable to cataract patients with CIDME. However, there is still a debate in clinical practice regarding whether post-operative anti-VEGF treatment is needed for cataract patients without pre-operative CIDME to prevent the development into CIDME. And some researchers have already reported that injecting anti-VEGF drugs after phaco immediately in eyes with DME can prevent the worsening of macular edema. And numerous RCT have shown that post-operative anti-VEGF treatment can significantly reduce the incidence of DME after cataract surgery. And next, I'm going to introduce our research. So our study basically aims to explore the effect of combined cataract surgery and concerct on the short-term occurrence and development of CIDME after cataract surgery in patients both with cataracts, NPDR, and NCIDME, and also investigating the changes in aqueous humor metabolites before and after cataract surgery, aiming to evaluate the correlation with pharmacokinetics and clinical prognosis. This is our inclusion criteria, so we focus on the cataract patients both have NPDR and NCIDME. This is our exclusion criteria. And our study is the RCT. The patients were randomly divided into the treatment group, which combines the cataract surgery and anti-VEGF treatment, and the control group conduct cataract surgery only. Aqueous humor samples were collected during and 1 week after surgery, and ophthalmology examinations were performed 1 week till 3 months after surgery. Metabolites in aqueous humor were analyzed using high-throughput targeted metabolomics techniques, and prognostic analysis were performed in combination with machine learning strategy. This is our preliminary result. We use both unidimensional and multidimensional statistical analysis. This is the PCA result, and this is OPLSDA analysis. And we can find that there are changes of aqueous humor metabolites in both two groups, but the control groups remains relatively stable pre and after operation. And this is the Venn diagram of differential metabolites screened by uni and multidimensional statistics. And we also found there are 2 common differences in metabolites between these 2 groups. Next, we have conduct pathway-associated metabolites enrichment analysis, and this is the result for the control group before and after surgery. And this is the result for the treatment group. However, there are no significant difference in post-operative BCV and CST between these two groups. In this case, we decide to re-divide our patients based on their prognosis result, mainly based on their CRT change before and after 3 months of surgery. And this is an example of good prognosis group, and this is a poor prognosis group. And we also found that there are several change of aqueous humor metabolized before and after surgery according to different prognosis group. So good prognosis group BCV and CS better, and also some of the metabolites change significantly in aqueous humor compared with these two different groups, which makes us think whether some of them metabolites have predictive meaning. So we have conduct several machine learning strategy, which are random forest, support vector machine, and brute analysis. And surprisingly, there are 4 metabolites in common with these 3 machine learning strategy. So these 4 metabolites can be the marker for the predictive meaning. And we also conduct logistic regression model to predict the ROC curve and PR curve. And finally, we have conducted correlation analysis of aqueous humor metabolites and systematic indicators. The mediating effects of blood markers, differential metabolites, and prognostic outcomes were calculated. And we do have found some of the blood indicators are really relevant with prognostic outcomes. So in conclusion, we found in diabetic patients, age, metabolite levels after cataract surgery remain relatively stable. However, the intraoperative injection of anti-VEGF drugs during the surgery can alter the aqueous humor metabolites profile, and differential metabolites are mainly related to these 3 pathways. And changes in metabolites levels are correlated with prognosis, and some metabolites reflect the mediating effect of systematic blood indicators on prognosis. And for patients who may experience worsening macular edema after cataract surgery, we suggest adopt personalized preventive measures such as anti-VEGF treatment. So thank you.
Thank you, Yuming. We move to the next presentation by Xingfa Zhang. Is it also online? Is there a recorded presentation for the next speaker? Okay, if not, we move to the next speaker, which is Sam Chaurasia. Huh? Which one? Which one, Zing?
Which one? Who's the presenting author?
No, I haven't.
We can play that later. I think we can
Yeah, we can.
Hello, everyone. I'm Jingfa Zhang from the Premier International Eye Research Institute of the Chinese University of Hong Kong, Shenzhen. So my topic is the intricate mechanism of subretinal fibrosis in neovascular age-related macular degeneration. I have no conflict of interest. So neovascular AMD is the leading cause of vision impairment in elderly people, and subretinal fibrosis is the end-stage sequelae of neovascular AMD, causing severe vision impairment. And currently, there's no effective treatment for subretinal fibrosis. And the prevalence of subretinal fibrosis increases over time. For example, at 5 years, the prevalence of subretinal fibrosis is about 56%. So we all know that for the neovascular AMD, intravitreal injection of anti-VEGF drugs are very effective to treat this kind of disease. These are my 2 patients, and 1 week after intravitreal injection, we can see the neovascular was reduced significantly and also with the reduction of the subretinal fluid and subretinal hyperreflective materials. And for most people, that after with the treatment or intravitreal injection of anti-VEGF drugs, the visual acuity was increased. However, for some of them, 2 years after the treatment, the visual acuity will decrease gradually, and at about 5 years, the visual acuity come to the baseline before the treatment. So this is mainly due to the persistent disease activity, which indicates that accumulation of the subretinal fluid and the enlargement of the new vascular vessels, as well as the hemorrhages and the progressive subretinal fibrosis. And this is when my patients who were diagnosed with neovascular AMD in his left eyes. He was treated with 8 times of intravitreal injection of anti-VEGF drugs, and the visual acuity was improved from 0.15 to 0.5. However, at the last time of his visit, we can see this patient still has the persistent disease activity, includes existence of choroidal neovascularization, subretinal fluid accumulation, as well as the subretinal fibrosis. So we know the pathogenesis for subretinal fibrosis is really complex, which involves many different kind of cells can become the myofibroblasts, the main cellular components of subretinal fibrosis. And also these cells can secrete a lot of different kind of extracellular matrix, so makes the subretinal fibrosis is really complex. And in the past several years, our group have studied the mechanism of subretinal fibrosis. So we found that the choroidal parasite can be involved in subretinal fibrosis through the mesenchymal transition into the myofibroblast PMT. And this pathway was mainly through the TGF-beta SMAD pathway and the non-SMAD signaling pathways, include the AKT-mTOR signaling pathway. And also we found that RPE cells can be involved in the subretinal fibrosis through the epithelial mesenchymal transition, and via the different signaling pathways like Wnt5A, beta-catenin, SMAD2/3 ERK signaling pathways, and it indicates that RPE cells are involved in this subretinal fibrosis. Actually, the subretinal fibrosis involves different kinds of cells beside the choroid parasite, RPE cells. Other cells are also involved. For example, the endothelial cells, macrophage, fibrocyte, etc. all can become the myofibroblast via mesenchymal transition. And to find the treatment for this subretinal fibrosis, our group found that one inhibitor is called, one molecule is called gamma secretase inhibitor, RO, can significantly increase the subretinal fibrosis as well as the choroidal neovascularization through directly inhibit Notch signaling pathway and indirectly inhibit the ERK signaling pathway. So we also found another molecules we call the luteolin, and this molecule can also inhibit the CNV and the subretinal fibrosis through the SMAD2/3 and YAP signaling pathway. Actually, the mechanism for subretinal fibrosis is really complex. So the red color labeled here are the reported signaling pathways or molecules are involved in the subretinal fibrosis, and the square colors, square with the green colors indicate that the study is the molecule to inhibit the relatively signaling pathway. And so that means the subretinal fibrosis is really complex with different molecular involvement, different cellular components, and also the different signaling pathways. So that's all. Thanks.
Dr. Shyam Chaurasia is not here. Then we can move on to the next presentation. May I invite Dr. Kurimoto to present the paper on a clinical study of allogeneic iPS cell-derived retinal pigment epithelial cell transplantation for retinal pigment epithelial impairment disease.
Okay, thank you, Chairpersons. My topic is a clinical study of iPS cell therapy for RP impaired disease. This is our COI. Although there is no established treatment for retinal degenerative disease caused by RP degeneration, we call this RP impaired disease. Transplantation of allogeneic iPS cell-derived RP may be a curative treatment. Up to now, we have conducted several clinical studies in different graft formulations. The first one was RPC transplantation. This was our first in-human RP cell therapy in all medical fields. And the advantage of iPS sheet transplantation is reliability. But disadvantage was intense surgical invasions. So next, we have tried RP cell suspension transplantation. The advantage of cell suspension transplantation is minimal surgical invasion, but we couldn't control the grafted cell under the retina, not at all. So this is a big problem. Then we have developed a new graft formulation, that is RP strips. This method combines the advantage of RP sheet and RP suspension, which means reliable transplantation and minimal surgical invasion. What is RP strips? RP strips are formed in narrow grooves in 2 days cultures. And these RP strips can be ejected with a 31-gauge cannula. This slide shows a preclinical study. In vitro setting, RP strips spread out on the plate and form a single RP layer. And in vivo setting, under the retina of the rat, a single RP layer with light polarity is formed. We performed the RP strip transplantation 2022. After creating a retinal bleb, iPS cell-derived RP strips were transplanted under the retina using a 31-gauge cannula. You can see the subretinally injected RP strips. We treated 3 patients. Case 1 was a dry AMD, and case 2, case 3 were meltic-associated retinitis pigmentosa. No serious adverse event occurred in all 3 cases. But in case 1, suspected immune rejection was occurred, but this was controlled by additional steroid and immunosuppressant administration. And in case 3, macular edema associated with ARM occurred, but edema was resolved by subtenon steroid injections. And POCT analysis revealed that this ARM was not originated from grafted cells. I will show the time course of case 2. This is a pre-transplantation. And I transplanted 2 strips, this area. So, okay, so 1 month, 3 months, 6 months, 9 months, 1 year. As you can see, the transplanted RP was visible immediately after transplantation, and the area of engrafted RP gradually expanded. In OCT images, you can see the cross-section of RP strips. In 6 months, 9 months, 1 year, as you can see, subretinally transplanted RP strips expanded their engraftment area into a thin and flat area, likely a single cell layer. The primary endpoint was reduction of RP abnormal area by transplanted RP. The changes in window defects were analyzed using an automated evaluation program with AI. As a control zone, which means untreated zone, RP abnormal area unchanged or tended to increase. In contrast, at the treated zone, RP abnormal area decreased, which means improved. The abnormal RP area decreased after transplantation in all 3 cases. The secondary endpoint was visual function. Most parameter was not changed, but in case 1, VFQ-25 score improved remarkably. And actually, this patient says us that she can now see well in dark places, and that she can see the stars in the sky, night sky, which she couldn't see before the treatment. QOV improved in dry AMD case. This slide shows MP3 results. In case 1, retinal sensitivity within vascular arcade improved in the treated eye, but in the fellow eye, sensitivity decreased. Conclusion, iPS cell-derived RP strips were successfully transplanted subretinally in advanced RP impaired cases using a minimally invasive technique. 1-year follow-up confirmed both safety and efficacy. Thank you for your attention.
Thank you. A very novel and interesting presentation. I just have one question. Is that your cases was, I think one was ARMD and 2 cases were retinitis pigmentosa.
One case is dry AMD and the rest of 2 retinitis pigmentosa with MERT mutation.
Okay, so how did you select the location where exactly to transplant these RP strips?
So we selected the transplanted site in where RP is gone, but photoreceptor is still alive. Donors, no, host's photoreceptors is necessary.
Yeah, I meant like the location, you know, how did you choose where exactly you want the RP strips to be transplanted?
Okay.
Like 2 were retinitis pigmentosa and 1 was ARMD. So, is it the same location in all the eyes? How do you choose where exactly you want the strips to be transplanted?
Okay, so one the surgical procedure is very important for a good transplantation. So the one reason is it's suitable for surgical procedures. And more important condition is, as I told, that area, RP was gone, but photoreceptor is still alive site.
Okay.
Did they have the same, do you know the mutation profile of these patients? What mutations they carried?
Sorry,
what genetic mutations were there in the patients?
In AMD?
In AMD as well as RP?
In AMD, we can identify the mutation, genetic mutation.
And in RP?
Yeah, it was mentioned in the
that
table.
That was only one
Merck
mutation?
mutations,
The Merck mutation.
Merck mutation was identified in 2 cases.
It's the same, and they were homozygous. Patients were homozygous for that.
So, yes.
Yeah.
In case 1, that was the first case, so I transferred just 1 strips. And the other 2 cases, I transplanted 2 strips. Because ethical committee restricted the 1 or just 2 strips for safety. And our next clinical study, we will transplant 4 or 8 strips.
What's the length of it?
Lengths are about 2 centimeters, which include about 2
millimeters.
2 millimeters.
No.
2 centimeters.
Oh, so sorry. 2 millimeters. Yes, 2 millimeters. Sorry. Which include about 12,000 RP cells. 12, no, so 200,000 RP cells. In the strips, it's random. But in animal experiment, after they transplanted and they engrafted, they find their own light polarities in vivo.
Thank you very much.
Thank you.
So is Dr. Fang Shi here?
Yeah,
Okay, yeah, thank you. So he's going to give the next presentation on the human-induced pluripotent stem cell-derived corneal endothelial progenitor-like cell recovers the rabbit model of corneal endothelial dystrophy.
Hello everyone, I'm Fang Zhi Xiao from Chang'e Memorial Hospital in Taiwan. Today I'll show you my interesting study. The human iPSC-derived corneal endothelium progenitor-like cells recovers the rabbit model of the corneal endothelium dystrophy. I have no conflict of interest. We all know that the corneal transplant evolved from the PK in 1931 and followed by DSAC and DMAC in 2006. The first allogeneic corneal endothelium cell therapy was approved by Japan in 2023, and a similar clinical trial with magnetic allogeneic corneal endothelium cell therapy is also ongoing. However, young corneal grafts are necessary for this kind of therapy. Ideally, endothelium cells from human iPSC might be a better treatment strategy. This year, Professor Shimura published the first human iPSC-derived corneal endothelium treat Pullers keratopathy in humans. However, gene mutation of the injection cells was found despite the whole genome sequencing of the master cell bank. The development of the corneal endothelium was from the neuroclast and the corneal endothelium progenitor cell. And to address the previous issues, we think that maintaining a therapy cells in the corneal endothelium progenitor phase might be a good solution. We reprogram the patient's peripheral blood mononuclear cells into iPSC and then differentiate into the neuroclast cells and finally into the corneal endothelium progenitor-like cells, which we call IHC-PLC in this study. With the contact inhibition, IHC-PLC will become the human corneal endothelium-like cells. We intracamerally inject the IHC-PLC into the BAK corneal endothelium dystrophy model and reconstruct the mononuclear corneal endothelium. In the BAK-induced corneal edema rabbit model, BAK-treated cornea shows fibrosis, and the IHC-PLC injections group show the mononuclear corneal endothelium-like cells presenting with a low one and a human nuclear antigen, which means that these cells are from the human instead of the rabbit. External eye photography shows the corneal opacity in the BAK-treated eyes, especially in the postoperative week 1. As for the IHC-PLC injection group, the corneal edema resolved faster than the control. As for the central corneal thickness checked by the A-scan, BAK-treated only group were more than 1,200 micrometers, while the IHC-PLC group presenting gradually resolved the corneal edema. Now let's overview the result. We generated the neuroclast cell-like cell from the PBMC-derived human iPSC and differentiated into the corneal endothelium-like cells. And the differential gene expression between the IHC-PLC and the primary HCEC indicates a progenitor-like state of the IHCEC-like cells. And the IHC-PLC restore the cornea clarity in the rabbit's BAK-mediated endothelium dystrophy model. And the IHC-PLC displays a long-term sustainable therapeutic effect. The conclusion of this study is we customize the patient's corneal endothelium progenitor-like cells through the molecular induction. And the IHC-PLC have characteristics of the progenitor cells and is capable of proliferation in vitro. And the IHC-PLC provide sufficient therapeutic cells for preclinical efficacy and a safety evaluation as well as treatment. And this study was published in JAR. And thanks for Professor Chen, Professor May, and Dr. She's guidance and others team members help in this study. And this is my presentation. Thanks for your attention.
Thank you. We open it up for questions.
Yes, please. Yeah, sure. Can you show my PPT? I have the other data. As you can see in the IFC PLC RNA sequence, we can see the IFC PLC here, the second line is, and the next line is the primary HCEC RNA sequence data. We can see it's a little bit different. It's a little bit different, but it has the characteristic of the cell injection therapy like the CD44 negative, CD160 positive, and the CD133 positive and negative, and the CD24 negative and CD26 negative characteristic. And also it has the characteristic of the proliferation characteristic. And in the immunostaining of the IHCC and the B4G12, the cornea endothelium cell line, we can see actually this is the similar presentation of the LO1 and ATPA1A, CD56, CD160C, and Candarin, and the collagen AA1. And for the quantitative RT-PCR data, we can see the IHCC with the content inhibition, we have the cell proliferation induction gene, and this left part is the IHCEC, and this is the B4G12 cell line, and we can see with the content inhibition, the proliferation activity will go down, and with the terminal differentiation gene will become increased. Currently, in the safety issue, we use the teratoma assay in the skin mouse, and there's compared with the initial IPS from the PBMC we inject into the skin mouse, and compared to the IFC PLC injection also in the skin mouse, there's no tumor found inside the mouse tissue.
Well, there is, if you go to the real-time data, if you go to the real-time data.
You mean what data?
No, the real-time PCR data.
Real-time PCR. This.
So the CD44 and the Wnt5b, if you see that there's a trend in the decrease.
Yeah.
But it's not. It's only less than a cycle difference, right? Or less than a fold difference.
Yeah.
So there's a trend, but it's not really significantly more.
It's compared with the initial part. Yeah. Yeah.
So anything less than twofold, as you know, is only a cycle difference.
Yeah.
It's kind of dicey. But we need to kind of look for more data.
Validate this.
Yeah.
With the content inhibition, they stop proliferation.
So what would be your next plan, having these results?
We are creating another kind of rabbit model, such as DSO, to check whether this kind of iPSC-derived cells can attach without the desmoid membrane.
So you'll be doing the safety and efficacy studies?
Currently, this data are only in the rabbit model.
Yeah. All right, thank you.
Okay, thank you.
I think the next speaker is not around, Dr. Rikan. So we move on to the next speaker, Dr. Ophthalmology, who will be presenting on knowledge and attitude about eye donation among medical and nursing students in a tertiary care center in Western Australia.
A very good morning to everyone present here. I will be presenting my paper on knowledge and attitude about eye donation among medical and nursing students in a tertiary care center in Western India. There are no conflict of interest. Corneal blindness is an important public health problem in India, but the widespread use of keratoplasty remains hindered by the relative scarcity of donor corneas. This has been attributed to the unwillingness of potential donors to place their eyes, as well as to the failure of healthcare workers to educate them about the process. So the aim of my study was to assess the knowledge and attitude about eye donation among medical and nursing students, and they included residents, interns, MBBS students, as well as nursing students. It was a cross-sectional study with convenience sampling, and the sample size was 500. As per the inclusion and exclusion criteria, 500 medical and nursing students in a tertiary healthcare center in Pune were administered a questionnaire about eye donation. Responses were recorded in Google Forms and converted to Excel format for analysis. The inclusion criteria included residents working in all the departments, preclinical, paraclinical, as well as clinical, students studying in first year to final year of MBBS, interns, as well as nursing students. The main exclusion criteria was the residents of the ophthalmology department in order to eliminate any bias. 59% of the participants were females and 41% were males. Majority were MBBS students, which was followed by nursing students, interns, and PG residents. So the questionnaire was divided into two halves, the knowledge domain and the attitude domain. The knowledge domain had 8 questions, and each of the questions was scored as 1 point. Only 35.2% of the participants were aware that either the cornea or the entire eyeball can be removed for donation. 47.6% thought that it is possible to specify who will receive the donated eye, and just 37.4% knew which media can be used for preserving the eyeball. So each of these questions was given 1 mark, and the total score was calculated out of 8. The knowledge was graded as excellent if the score is more than 6, as good if it is between 4 to 6, and as poor if it is less than 4. Only 9% of the population of the participants had excellent knowledge about eye donation, and 20% had poor knowledge about eye donation. Only 49% were willing to donate their own eyes. Please note, this is not the lay population. These are the medical students who will be the future healthcare workers of the country. Only 33% were willing to donate their relative eyes, and only 35% were willing to donate eyes for research or training purposes. So we inquired about the reasons for the unwillingness or undecidedness for donating their eyes. Majority answered that they need more information about eye donation and the transplantation process, which was followed by the reason that their family won't be supportive of eye donation. Some other reasons also included that I have high myopia. I haven't discussed with the family yet, and even that it will hamper my vision in the next life. So we discussed about the motivating factors which will have a positive impact on the participants about eye donation. So majority were of the opinion that if they get more information about eye donation and the transplantation process, they will be more positive towards eye donation, which was followed that if their family member or a friends need a corneal transplant, then they will be more positive. So from the study, we found that only 9% of the students had excellent knowledge, while 20% had poor knowledge about eye donation. Only 49% were willing to donate their eyes. 42.6% needed more information regarding the subject, and 44.8% participants would consider donation if they had more information on the subject. So there is a need to impart knowledge and modify the attitude about corneal transplantation among medical and nursing students, since they will be playing a major role in educating and motivating potential donors regarding eye donation in the future. Mass education and awareness programs are also needed to encourage the attitude of family as a unit, since many of the participants were hesitant for donation because of lack of family support. These are my references. I would like to conclude by saying, आँखों की खूबसूरती पर बेपनाह लिखने वालों, आँखों की खूबसूरती पर बेपनाह लिखने वालों, एक निगाह उन पर भी डालो जो देख नहीं सकते. I request everyone to please pledge their eyes for donation. Thank you.
Thank you.
Thank you.
Are there any questions? Were the level of education same amongst the medical students? Like they were either, did you adjust it for their duration of education? Like They were first year graduates
No, sir.
or say,
Everyone was included, like from first year MBBS to final year interns, the residents, everyone, and the nursing students of first to final year. Everyone was included, and we were assessing the knowledge in this group because in the future they are going to be the future doctors.
So you are analyzing the data collectively, but did you do any subgroup kind of a thing, like those who were beginners versus those who actually had a...
No, sir, that kind of differentiation was not done.
You also had some residents, I think.
Yeah, it has some residents also. Yeah.
So subgroup analysis, as sir suggested, would
Yes.
probably
Bring out some
more
insights.
information, more insight.
Yes.
And you can do that as a secondary
Yes, ma'am.
data. Any other questions? All right, thank you very much.
Thank you. Thank you so much.
I just wanted to check if if our last speaker, Dr. Yiqian Zhang, is here. Not here. So since we have finished before time, are there any questions to any of the speakers?
If there are any recorded presentations.
No, they have completed here. Okay, so if not, we'll conclude ahead of time. And thanks to all the speakers and the audience and to my co-chair. It has been a great learning session. Thank you very much.
Thank you very much. Maybe we can all have a group photograph
All
as
the
a memory.
speakers, all the speakers.
We invite everyone to join us for a group photograph.
I couldn't hear.